Hello everyone. So I'm going to show you this RF coagulation technology for discogenic pain, neck pain basically, and the cervical disc herniation. So this is a good like advanced intervention for the cervical discogenic pain. So far we do not have any interventions which is like effective, or maybe it is too complex for the cervical procedures. As a pain physician, I think this is one of the best available tool with you, where you can manage your patients who are suffering from chronic discogenic pain and minor herniation, where we do not have any cord compression or the spinal uh, exiting roots compression. So in those cases, we can use this technology, which is a very minimally invasive and very safe technology and very effective also. So I'm going to show you this case and also the procedural steps, some technical consideration while performing this procedure. So this patient, you can see here, this is a cervical spine MRI, the axial sections, the coronal sections, and the sagittal sections. In the axial sections, you can see sagittal sections. You can see over here, there's a minor herniation over here at C5, C6 level, 2, 3, 4, 5, 6. Sorry, 6, 7 level. You can see there's a minor herniation over here. And that is not compressing the roots, but it is basically indenting the thecal sac and just touching the spinal cord without distorting the spinal cord contour. So we can see this MRI on the axial section. So this patient is a young patient, and now we can see here this is a big tear here in the axial section. You can see there's a big tear over here, right? This is annulus over here, and this is a big tear. So this patient is having severe neck pain. This guy is basically founder of one of the web designing company. So obviously he has a lot of sitting job, which is basically like almost 8 to 10 hours in a day. At times it goes up to 12 to 14 hours also in a day. So he's been suffering this back pain, sorry, neck pain since last many years, but it has aggravated so much that now he's not able to sit. Even he cannot concentrate on the laptops or his work. So he was in terrible condition. There was hardly any radiation to the arms, but at times he says that if he sits for a long time, some maybe 30, 40 minutes, more than 30, 40 minutes on computer, he starts getting radiation in the arms. Now this radiation was either on the right side or the left side, uh, never been to one side or both the sides together. But at times it is on the right side or the left side. So this is the ideal case where we have this kind of scenario where the patient comes with a lot of neck stiffness and occasional radiation to the arms. Why it is important in the neck region, cervical region, especially the interdiscal procedures, we as a pain interventionist, we must understand this anatomy very well, because this is very complicated. This is a very complex area where we have a lot of tissues which are there, which are of significance. We have thyroid tissue, we have trachea, we have esophagus, we have carotid arteries, we have jugular veins, we have vagus nerve over there. So these are various important structures which are there where before we reach our target area, which is our disc. So that is why the technical consideration is really important here to understand, and how we can manage to reach our desired disk or our target disk without causing any damage to the surrounding structures. So this is what we am going to show you, how you can do that. So these are the procedure steps. So this is the cervical FX system which we used for this patient, because there was a big tear. There was minor herniation also. So my target in this case was to basically seal the tear over here. That means the adrenoplasty also. And since there was a small herniation also, central herniation, I wanted to shrink the disc also. So this is one of the technique where we can do disc denervation, and also we can do disc coagulation. So this is a plasma coagulation system. So we can, if the patient is having only discogenic pain, that means only the nerves are our target, internal nerves are our target. We can do nucleoplasty with the disc system. But if our target is also coagulation, we can use coagulation in the same machine. So we have both ablation and coagulation in the same machine. So depending on the type of the disc pathology, we can select our disc FS system, which one we want to do. So this is the position of the patient. Normally, we put a pillow under the shoulder. We extend the neck towards the left side. We always go from the right side, whatever side it is. Prefer on the right side, because on the left side we have some esophagus, so we avoid a left-sided entry. You always go on the right side, and this is how the neck is extended towards the left side, and this is the area of the entrance. Now, as we saw in the axial section of that anatomical axial section, we saw that there are multiple vessels over there. We had to negotiate with those vessels. So this is the technique. What we have modified is that we do hybrid. Hybrid means we use ultrasound while going inside, so that we can avoid major vessels and the thyroid tissue. So the technique is basically the patient. Now this patient is lying supine with the head extended towards the left side. And this is our target area. First, we identify our target area. Once we identify the target area, we go for the parallelization of the end plates, as we do for the discal procedures. So here also we do the parallelization of the end plates. We identify our level. Now you can see here from this one, this is the T1, this is the first thoracic, first rib, which is attached to the first vertebrae over here. So this is a T1, this is C7, this is a C6. So this was our area of the interest. So we had to go for the parallelization of the end plates of these two, C6 and C7 vertebrae over here. Once that is done, now we had to start going oblique, ipsilateral oblique. When we go ipsilateral oblique, you can start seeing this transfer process is going towards the opposite side. And once it goes to the opposite side, we can see over here, we can look at it over here. We can see the uncinate process over there. That's the uncinate process. And now we can see here the end plates, the lower end plate of the C6 and the upper end plate of the C7, and in between we have a intervertebral disc. So this is the entry point when we want to go inside a disc in the cervical region. We identified our level. Once again, we have confirmed our level. We can see the uncinate process. Now, before putting our trocar, the spine vent, what we use for the disc FS system, cervical disc FS system, normally what I do is I go with a 22 or 25 gauge needle. You can use both of them, either of them. You can maybe 25, that is also visible with the ultrasound, or you can use a 22 gauge needle. So depending on the size of the patient, if the patient is very thin, you can use 25 gauge needle. If the patient is thick, neck is thick, in those cases, you can go for the 22 gauge needle to basically see the trajectory and also to anesthetize up to the annulus. So this is what we do, is we go with the 22 gauge needle. You can see I just anesthetize the entire area over there, and then I'll come out. Now this you can see here on this side, you can see, now you can see here, this is the ultrasound probe. This ultrasound probe is basically showing me the trajectory of this needle, and it is avoiding the entire important structures, especially the carotid artery. There are some arteries which are there, aberrant thyroid arteries are also there, thyroid tissue is also there. So we have to avoid all those. So this tool is going to help you a lot while going into the cervical disc, entering the cervical disc. So once we anesthetize everything up to the annulus and the entire tract, and then we use a this is the probe which goes inside. This is a introducer. With this introducer, now again you can see here we are using a ultrasound probe. We just go medial to the uncinate process. We'll go up to the annulus. Once we reach the annulus, then we are safe. Then we don't require our ultrasound. Once we reach the annulus, we have crossed all the important structures. Now you don't require ultrasound probe here. We check AP view. In the AP view, we can see that when you enter the annulus, we are just at the lateral wall of the vertebral bodies over here. And then we start advancing in the lateral view. So once we advance and then we check in the lateral view, we can see here We can advance more. And so that's a vertebral body over here. That's a vertebral body over here. And we are in the center of the vertebral body over here. So annular tear is somewhere here, this side, post anteriorly. The posteriorly over here. This is the area where we have annular tear. So in this case, I would like to go slightly to the anterior 1/3. Otherwise, if you want to target only the disc, where our target is the denervation of the disc, in that case, we don't have to go anteriorly. You just have to keep it in the center of the disc. So once again, we can see over here, and here I'm just advancing slightly anteriorly because I want to target the posterior anterior annulus. Sorry, the posterior annulus over here. Now we have reached over here, and then we are still in the center. We are not crossed the center. We will check with the contrast, and now with the contrast, we can see this contrast is basically gone into that annular tear over here. We'll keep some margin. We'll always keep some margin because this vent, when we remove the stylet, we have to put this vent. With this vent will come out of this introducer. So we have to keep some distance between the posterior and the posterior annulus and the disc and the band wire. So this you can see here. This has come out of this. This is the spine band. This is coagulation RF coagulation band which has come out, and we can do the lesioning. So as I mentioned, we have two types of lesions. We can do either ablative or we can go for the coagulative. So in this case, we use both because patient was having discogenic pain. We wanted to target the nerves also, and we wanted to shrink the disc because patient was having minor herniation also. So with the shrinking of the disc, the annulus is going to get closed over there. So here now you can see here, this is the band over here, and this is what I'm doing is I'm just targeting the posterior annulus over here. So whenever you are doing this RF, whenever you do this RF coagulation, remember you don't press it for more than 8 to 10 seconds. Recommended at 10 to 12 seconds, but I want to keep it on the safer side. Just keep it 8 to 10 seconds. Before going for the 8 to 10 seconds, you just give 1 second or 2 seconds of burst, just to check whether patient feels something. If the patient says that I'm having some tingling all over the body, or I'm having some sudden radicular pain in the arms, that means you're too anterior, you're too posterior. So that means you are covering the nerve also. So you have to withdraw your trocar and you have to come to the center of the disc. This is how we can see here with the to and fro movement. We are going and we did the lesioning of the cervical disc. And then you come out, put a pressure over there. So post-procedure, keep the patient under observation for at least 2 hours in the recovery room. Observe them closely. We can discharge the patient same day. Normally we do it same day discharge only. Oral antibiotics we must give for 7 days. Cervical disc, any disc procedure, that is our protocol. We give 1 to 2 hours before the procedure. We give IV antibiotics. On the same day, same night, we give IV antibiotics. The patient is admitted in the hospital. But if the patient is not in the hospital, if you have discharged the patient, we put them on oral antibiotic for 7 days. That is our protocol. We also give some anti-inflammatory and muscle relaxant because at times these patients will have increase in the neck stiffness after this procedure. So you must give good relaxant, muscle relaxant, at least for 3 to 5 days. And along with this cold or hot fomentation, we can advise them. Advise not to go for any strengthening exercises. Mild stretching exercises, you can explain them, but they should not go for any strengthening exercises for at least for 2 weeks. So these are the precautions we must explain to the patient. Very simple procedure, provided you understand the anatomy well. If we have this hybrid technology, if we have the ultrasound available, That is the best. Till the time ultrasound was not available, I was doing only under fluoroscopy guidance. But yes, with ultrasound guidance, the confidence level has definitely increased. So all the best, guys. So this is the video about cervical discogenic pain and cervical disc herniation, and we use RF coagulation technology for the treatment of chronic neck pain. Thank you so much.